My name is Matt Seidel. I'm an orthopedic surgeon in Scottsdale, Arizona. I'm originally from Phoenix. I did my medical training at Maricopa County Hospital in orthopedic surgery and a fellowship in orthopedic oncology at MD Anderson Cancer Center. Currently, I practice in private practice in Scottsdale, and I do quite a number of hip and knee replacements. The way you would know you would need hip replacement surgery is when you're having significant pain in your hip and none of the other non-operative treatments haven't worked, such as injections or physical therapy. We would also have an x-ray done of your hip, and if that showed severe or bone-on-bone osteoarthritis, along with stiffness and pain in your hip, then you'd be a good candidate for hip replacement surgery. Well, first of all, we've gotten completely away from what was known as metal on metal. Those caused all kinds of bad reactions in the body. Now we're left with what's on the socket side and what's on the ball side. Both the socket and on the ball side will be anchored with metal to the body. The socket will have a plastic insert into it, which is made out of high density plastic that's very strong. And on the ball side, we have the option of metal or ceramic. Current understanding of the way that a ceramic ball or metal ball will wear out the plastic is that the ceramic will last longer and not wear the plastic out. So currently, I think the best option is for a hip replacement to contain the high density plastic on one side and a ceramic ball on the other side. As long as the patient has a problem that can be fixed with hip replacement surgery and any potential complications from either being overweight or any other associated diseases are well controlled around the time of surgery, it can be done safely. Well, first of all, it's interesting that very few people with severe osteoarthritis also have severe osteoporosis. The main category we see are people with severe osteoarthritis and mild or moderate osteoporosis. Well, first of all, if you have a medical condition that precludes you from having anesthesia, obviously you can't have surgery. Other contraindications would include a severe allergy to the metal or the plastic implants, or if there is an ongoing infection in the body which can't be controlled, or even worse, an ongoing infection in the joint that's going to be replaced which can't be controlled. Those would be contraindications to having hip replacement surgery. Posterior hip replacement surgery is full of precautions. You can't flex your hip past 90 degrees. You can't internally rotate very far for 3 to 6 months. After anterior hip replacement surgery, there are no restrictions. In general, within hours. The physical therapist will generally get you up and have you walk with the walker as far as you can. After going through the proper rehab and reestablishing the appropriate range of motion and strength of your hip, you'll be able to ride your horse safely. I have many patients that do so right now. Running is probably the exercise that will wear out your hip the fastest. Sort of like the tread on a tire of your car. The faster you drive and the harder you take your turns, the more quickly you will run out of the tread. I try to discourage my patients from running. I instead encourage swimming, biking, hiking, and elliptical. Most patients use a walker for about 1 week. When I see you back in my office after 2 weeks, you will likely be off of the walker and either using a cane or nothing at all. Most patients with a light job, such as a desk job, are back at work in 2 weeks. More heavy-duty jobs, usually 4 to 6 weeks. I like the patients to be able to walk unassisted and without a limp before returning to heavy-duty jobs. For most patients, you can go back to driving after anterior hip replacement surgery when you no longer need your walker for ambulation. This is a very well studied surgery, and all of the complications are very well understood and very well controlled. The two most common complications are those of dislocation and infection. Because of the way the implants are put in and the antibiotics we use around the time of surgery, these complications should occur far less than 1% of the time. Other small complications which patients might have is some numbness around their incision site or some ongoing pain in their hip while the hip is healing in. The vast majority of these infections are small infections in the skin near the incision. These are easily treated with a 1 to 2 week course of antibiotics, and patients recover without any problems. In the very rare case there's a deep infection, this might require additional surgery. The anterior hip replacement cuts no muscles and therefore has the quickest recovery. In addition, it is the most stable hip replacement. It has the lowest rates of dislocation. That's the best approach for hip replacement surgery. I started doing anterior hip replacement surgeries approximately 8 years ago. At that time, nearly everybody was still doing posterior hip approach, and I switched because I realized the obvious benefit of cutting no muscles. Since then, I've done hundreds of anterior hip replacements per year with good results. Well, many years ago, when everyone was doing the posterior hip approach, we wanted to make that incision smaller and less traumatic. And this is where the PATH came in. Percutaneously assisted total hip replacement is what PATH stands for. And essentially we have a small tube or cannula which can be placed through a smaller incision away from the main incision, and then we can use our instruments through that cannula to precisely place the hip replacement without a large incision. While using the tube or cannula, we're able to place our instruments through this tube or cannula in order to make the incision much smaller and the muscle trauma much less. In the traditional anterior hip replacement, an incision is made in the front of your thigh about this long. This allows us to do the work we need to do to replace the ball and the socket. Using the PATH instruments, where we have a tube or a cannula, we can now make a smaller incision directly over the hip joint and a smaller, even yet incision down here where we can place the tube through the muscle up into this area and do our work without damaging any of the muscle. The old incision, despite being smaller with the anterior PATH version 1, is still in an awkward location and painful. Moving this into an area directly over the top of the hip joint, it becomes more cosmetic, it heals better, and it's much less painful. This mostly has to do with your other medical conditions. Patients that are otherwise fairly healthy without any significant heart or lung problems are in general good candidates for outpatient anterior hip replacement surgery.